Recording. Okay, so understanding and managing antidepressant side effects. We are used to consider antidepressants, SSRIs, very safe. And now I think very few of us use tricyclics, maybe just in case very severe depression or psychotic depression. So we always use SSRIs, citalopram, escitalopram, sertraline, and we usually consider them very easy drugs. You heard about antipsychotics, so we are always a little bit afraid, the risk of tardive dyskinesia, risk of neurological effects. With SSRIs, we are comfortable. But in this presentation, I would like to give you some specifics that it is real that SSRIs are more tolerable than tricyclics, but they may have some issues that we should be aware of to avoid problems. So, SSRIs are usually well tolerated, but still there are some issues. Of course, if you read the side effect in the label of the drugs, you see a lot of side effects. Many are very rare. And of course, that can happen with almost any drug. Some are more common. For example, SSRIs consider that they can influence the bleeding time because they block serotonin transporter and so influence serotonin in the platelets, and bleeding in some subjects can be an issue. Another very common side effect is the sodium decrease, particularly in elderly patients. So there are many side effects to keep in mind when you're prescribing an SSRIs. But the one that I told you and some others that are in the label and literature, you just know them and you can manage them. What I will talk you today is something more uh, specific and useful, that is the difference across SSRIs, across drugs, on side effects that are quite common. So for bleeding, there is not much we can do. All of them give bleeding. And also the sodium decrease, almost all of them give the same one. But today we will talk about other aspects like weight gain, sexual dysfunction, insomnia, gastrointestinal symptoms that are not the same across all antidepressants. So it's extremely important, and I hope that this presentation will be useful for your clinical practice, to know that which drug has a specific profile. So if a patient really doesn't want weight gain, you should not prescribe the drugs that give more weight gain. Same for sexual dysfunction and other aspects. Of course, there is no perfect drug. We have to find a balance. Every patient is different. Some patients really tolerate more some kind of side effects, others tolerate others. And then there is a final slide about future antidepressants that will be for sure better tolerated, but they are just coming in the next few years. So just one slide to tell also why we are focusing on side effects. Because side effects is what differentiates more all the available antidepressants that we have. Because efficacy is very similar. This is one of the largest meta-analyses made on efficacy to try to see which is the most effective antidepressants. They are very similar. There are some bias, in my opinion, due to the analysis. Amitriptyline looks better, probably because of the anticholinergic side effects that improves sleep and anxiety very quickly. But probably reboxetine is not the strongest antidepressants that we have ever seen. But all the others, as you see, have similar side effects. So there is not a better antidepressant. The point is that we have to focus a lot on side effects. Let's start first with a concept. Side effects are related to the amount of the drug that patients have in their blood. That is quite simple. And so the plasma level of the drug is extremely important. When you prescribe, in this case, we are talking about a paper on escitalopram. When you prescribe escitalopram, 10 milligrams escitalopram, see you next week. But consider that half of the patient will have a different plasma level than expected. Poor metabolizers, rapid metabolizers. And so it can happen that if you give the same dose, some patients will have a very low plasma level. Some patients will have a very high plasma level. And about half will have the right plasma level. And after 3 months of treatment, if the patients have a very low plasma level, and we calculated in this paper below 20, these patients here, that are quite a lot, by the way, these patients here don't benefit from escitalopram because it's not blocking serotonin transporter in a sufficient way. And we have this other part with high plasma levels, above 80, above 100. Here are just few patients, but to give an idea, that if plasma levels are too high, they have a lot of side effects. So this is the first step. This is why I put the beginning of the side effect story. Side effects are important, but side effects are correlated with plasma level. So the first point, very important, that I would like to make today and for you to remember, to avoid side effects as much as possible and to keep efficacy, you have to stay in the middle range of the plasma level. If you are lucky that you have a laboratory, you can do the blood analysis. But I understand that also in Italy and many countries, it's not so easy and expensive. So if you don't have a blood analysis, try to use clinical experience. If you don't see any side effects at all, not a little sweating, just nothing, probably you are in the low range. Then you can increase. If the patient is complaining about sweating, about nausea and things, probably you are in the high range. Then you should go down. It is imperfect. It would be better to have blood level, but not where always is possible, I understand it. In any case, keep in mind, stay in the middle range of the plasma level. And depending on the patient, this could mean give high doses if it is a rapid metabolizer or very low doses if it's a poor metabolizer. I had many patients that I remember I treated with 2, 3, 5 milligrams of paroxetine because they were very poor metabolizers. And others, of course, you have to go for paroxetine also to 50 or 60 milligrams. And the same happens for duloxetine in this other paper that we did recently. Exactly the same. After 1 month, after 3 months is even more clear. If the plasma level is below a certain threshold, 10% of the variation, the efficacy is much less. And efficacy is much less for high doses. Here is even more clear. And here you have also side effects, a lot of side effects. So bad efficacy here, high effects here, side effects here, optimum treatment in the middle. So plasma level is very important to avoid side effects and to have efficacy. And this is the latest meta-analysis where in my journal, by the way, International Clinical Psychopharmacology, we publish all together escitalopram, duloxetine, mirtazapine, and other antidepressants, and really it is the same for all of them. So this is a fact that has been included also in guidelines recently, so it's something very useful for clinical activity. Okay, so we discussed the first point that is the plasma level. Okay, everything is right. Now let's go a little bit more in detail about the common side effects that are, however, different across compounds. Unfortunately, guidelines are not very useful for this. I always suggest to use guidelines to my students because they are useful. There are a lot of very useful guidelines. One of the best is CANMAT, but also the Maudsley, they are very useful. APA, they sometimes are a little bit old because I don't know why they take a lot of time from one edition to another. NICE are very detailed but less clinically oriented in my opinion. So Maudsley and CANMAT probably are the best, but still, even if they're so good, they don't go into detail to explain you which compound, which drug has higher or lower specific side effects. And this is why you have to go to literature, to the meta-analysis like the ones that we did in the last 10 years. And we have to do this because patients otherwise are not compliant. You probably know, but I'm remembering you now, that it is estimated that half of the patients, 50% of our patients, don't take the drug as we prescribe. Or they don't take it at all. Or less, or at all. They don't take it. And sometimes they don't even tell you that they don't take the drug. So the compliance for outpatient, of course inpatient is different, but for outpatient, compliance can be as low as 50%. And the reasons are many. The stigma, they are not convinced that the drug is useful, typically depressed patients are skeptical about treatments. But one very strong reason is tolerability. Oh, the doctor gave me this tablet, and it gives me stomach ache, and my depression is still the same, because of course it needs 2 or 3 weeks. And then they drop the treatment, of course. So it's important to reduce the poor compliance to explain and find the right drug for every person. More interesting, in the last few years we did some papers and an opinion paper on a very delicate matter that not all our patients have similar needs. If a patient is a high occupational level, think about an engineer that should build a building like this one. He needs to be concentrated about the metrics and things that he has to do in his job. Maybe compared to another patient that doesn't need to be so much concentrated. Then, if in such a patient you give a treatment that is reducing the cognitive function, like concentration, attention, the patient will drop, or you can do more damage. So you have also to consider which are the needs of the specific person. And we have seen that in these patients, the rate of dropout and adherence to treatment is lower sometimes. Because if you give mirtazapine to a lawyer, it's not the right choice. Or amitriptyline, even worse. Okay, let's start with specific points. Weight gain. I put weight gain at the beginning because it's always what my patients ask me. Please, doctor, don't prescribe me a treatment that is making me gain weight. Okay, because usually when they gain weight, they don't like it, they stop treatment, and of course there is a big risk of medical illness. With antipsychotics, you see increases of 10, 20 kilos sometimes, but also with antidepressants, you see increases of 3, 4, 5 kilos, sometimes even more. So it's quite important. And so, a few years ago with Laura, we did this very large meta-analysis that is quite famous now, to see which are the drugs that give more weight gain. And then we have an answer. At least we have a metric. Of course we suspected this, but now we have numbers. Amitriptyline, of course amitriptyline. Amitriptyline is a tricyclic, anticholinergic, antihistaminergic, so it increases appetite, so it makes sense that people gain weight. Similar for nortriptyline and mirtazapine, of course. All of three gave about 2 kilos in the acute treatment. Acute treatment means 1 month and a half. So 2 kilos in a very short time. Some neutral ones and some that showed a reduction, but this only in the acute. And I was not convinced of this result, because it was not what I see in clinical practice. Therefore, we did another analysis. That is what happens in the maintenance treatment. Not in 1 month, but in 6 months, 1 year. And it's very interesting that after 1 year, the situation is different, because there are effects of adaptations. At the beginning, a lot of people can lose weight because of the depression, because of the gastrointestinal side effects that we will see later. But after 1 year is different. And in fact, after 1 year, all of them give some kind of weight gain. Again, of course, mirtazapine and amitriptyline give a relevant weight gain of 3 kilos. But also paroxetine appears. Why paroxetine? You know paroxetine. Paroxetine is anticholinergic, so again, good for anxiety, good for sleeping, but not good for eating because they increase appetite. Then we have citalopram that you know is different from escitalopram because citalopram is more anticholinergic. So it increases more the appetite compared to escitalopram. Duloxetine and amitriptyline are anticholinergic, some neutral effect of sertraline and fluoxetine, and this is interesting, is bupropion. Bupropion also in the long term, after 1 year, it gives weight loss. So this is a very important and interesting thing. If a patient is gaining weight, for example, with paroxetine, but we cannot switch paroxetine because it is working for depression, then we can add a little bit of bupropion, 150 milligrams in the morning, to balance things and improve also the energy. There are differences from one drug to another. Amitriptyline is increasing weight since the beginning. Another, like fluoxetine, is increasing weight only at the end. At the beginning, no, I remember many years ago, probably you were not working at that time, the fluoxetine company told that fluoxetine was good for losing weight. And indeed, this is real for the first months, but not at the end. I remember many patients that I give fluoxetine because they wanted to lose weight, depressed of course, but they told me that after 1 year they gain weight. I could not believe it because I said, wow, but it's impossible. Fluoxetine is making lose weight. But it was real. And in fact, after 10 years, the meta-analysis demonstrates that also fluoxetine in the long term gives weight gain. Citalopram similar, but not escitalopram. You see the difference between citalopram and escitalopram. Duloxetine quite neutral, sertraline quite neutral, and bupropion weight loss. In the title there is also management. So what we can do to avoid weight gain when we prescribe antidepressants? Well, the first thing is, of course, psychoeducation, to give all the possible suggestions about what to eat. You are lucky because the diet in your country is very well balanced, Mediterranean diet, but still try to avoid the usual thing, complex food, high calorie food and things. And psychoeducation means also physical activity that is also good for mood and anxiety and so on. But it may not be sufficient. And then, second step is dose adjustment. When you reach improvement with, for example, 50 milligrams of paroxetine, you can go down. Usually maintenance is to keep the same dose for 6-9 months. But if the patient is okay and there is weight gain, you can go to 30, 20, 15, not lower maybe. And this could be of help for weight gain. If the two doesn't work, then you have to switch. You switch the antidepressant with another one that in the ranking is lower. Or you add bupropion, or you can add topiramate. Topiramate is very good for weight loss. When I used it, patients lost something like 3, 4, 5, 6 kilos in few months. But consider that is off-label. The pyramid is an antiepileptic. Antiepileptic is not antidepressant. So you have to be very careful in the informed consent and things.
Do you use metformin?
Metformin could be useful, but from what I know is more useful for weight gain induced by antipsychotics, not by weight gain induced by antidepressants. I'm not aware of any studies of metformin and weight gain of antidepressants, but probably it would be a good idea to study, but is well known for antipsychotics more. But it looks that metformin could be the drug of eternal life, some people say, because it's so beneficial on everything, maybe also here. Sexual dysfunction. Sexual dysfunction is another point that is quite critical because a lot of patients, more than half, probably 70 or 80% of patients with SSRI have sexual dysfunction. And the big problem is that usually they don't talk about it. Probably they are shy or they don't think it's important. But this is a common reason for them to stop the medication. Because sexual dysfunction is compromised during depression. But when the patient is better and sexual dysfunction remains, is a big problem, of course. And then we did this other meta-analysis with Alberto. And we were very surprised to see that sexual dysfunction is very different across drugs. Very. Look, the scale here is from 0 to 90. It's not a narrow scale. It's the maximum scale. From 0% to 90%. So we have 5 drugs that give sexual dysfunction related to antidepressants. So not sexual dysfunction when they have depression induced by antidepressants, at 80, 70, 80 or even more percent. Who are? Fluoxetine, paroxetine, citalopram, venlafaxine, and sertraline. So we know for sure that if we prescribe one of these 5, almost all our patients will have some kind of sexual dysfunction. That could not be a problem for some, but could be a problem for others. It's important that we know it. Then we have an intermediate group, mirtazapine, fluvoxamine, escitalopram, different from citalopram, duloxetine, that have a sexual dysfunction less than half of the patient. And then we have the usual bupropion that is inducing sexual dysfunction less than placebo. So bupropion is activating. Sexual activator. That is not surprising because it's a dopamine reuptake inhibitor. So increases dopamine desire, so it's okay. And agomelatine also it seems very well tolerated. And this is more or less similar on the 3 phases, but with some differences in terms of desire dysfunction, arousal dysfunction, and orgasm dysfunction. You can see this in the paper. What you can do in terms of management when you have sexual dysfunction? Well, again, first, psychoeducation. If you explain to the patient that there is this possibility, this is something that is useful. This is something that is useful because you can explain to them that, listen, there could be a small effect on one or more 3 phases of the sexual activity. Don't be afraid, don't overestimate them, and we can manage somehow. So this is very important to explain. Then you can reduce the dose. If you reduce the dose, sometimes the effect disappears. If the 2-step doesn't work, then you have to switch to another drug that is not causing sexual dysfunction, like agomelatine or bupropion. Or you can add bupropion. Or at the end, you can add the usual sildenafil or tadalafil. I did some time, but of course this is really the last step because you are prescribing a compound, a drug that is not basically needed. You prescribe a drug to treat a side effect of another drug. That is not extremely correct, but in some specific cases could be an option. Another point, sleep and wakefulness cycle dysfunction. This is also creating stress, non-compliance, increase for medical problems, and cognitive impairment mainly. This is a very old survey that has been done in Italy, not by me, by a colleague in Rome many years ago, across psychiatrists, and they were asking, what do you think? This drug is more sedative or activating? For example, the answer is, what do you think about fluoxetine? And many people say that fluoxetine is activating. Very few people say that fluoxetine is sedating. But it's very funny when you look at venlafaxine or sertraline, where about half of people thinks is activating, half of people thinks that is sedating. And what is even more funny is that some people think that amitriptyline is activating. I don't know why they can think that. Amitriptyline activating is something that I've never seen in 30 years, but it can be said by some of the colleagues. So these are personal opinions. I put this slide to show you how it's important to do meta-analysis. Because if you base on personal opinion are based on one patient, some memory, distorted memory sometime, old books. So personal opinion are extremely dangerous. This is why you need data. These are not data, these are opinion that creates confusion. And the data are this one that we published a few years ago with Alberto. Which drug give more insomnia? Again, it's not surprising, but it's useful because the ranking is large, from 0 point something to more than 2 of odds ratio. It is quite a lot. It's not surprising that the drug that gives more insomnia is bupropion. So, bupropion is a wonderful drug in terms of weight gain and sexual dysfunction, but a terrible drug in terms of sleeping. We have to know this. And which the best? The best is agomelatine, of course. Agomelatine is modulating melatonergic receptor, so of course it is a sleep inducer and sleep modulator, and mirtazapine as well. And then there is an intermediate situation with others that should be considered. You know that sertraline also is giving insomnia because sertraline is also active on the dopamine transporter, similar to bupropion. So this is a very useful ranking for you. You can keep this ranking in your outpatient room or in mind when you need. Well, the patient doesn't want insomnia. Okay, don't use the drugs here. Use these ones. Or the opposite, somnolence, that somehow are correlated because somnolence can be due to also to poor sleep, but not only. So for somnolence, we have the lowest rate for bupropion and agomelatine, the opposite than we have seen above. And for somnolence, the highest is fluvoxamine. Fluvoxamine, you know, is a strange antidepressant that has also some effect on other receptor, like sigma-2 receptor. It has been used a lot in delusional depression. Some people say that there is some kind of antipsychotic effect of fluvoxamine. So fluvoxamine is not the ideal drug if you want a perfect wakefulness day, but is very powerful as an antidepressant in delusional depression. So you see how it's difficult because every antidepressant has its own specificity. Every antidepressant is better in some patients and worse in other patients. Fluvoxamine, for example, for somnolence is not the best. Also, paroxetine is given somnolence because it's anticholinergic and mirtazapine, of course. So what to do? How to manage sleep problems? Well, again, psychoeducation. Psychoeducation for sleep in mood disorder is crucial. Patients have to go to sleep always at the same time. less more than half an hour, but always in the same time. The regularity of the wave of the hormones is crucial in mood disorder. So regularity. When a patient is making shifts in a factory, working at night, I usually make prescription that should not do it. If you don't sleep one night every week, it's very dangerous for mood disorders, bipolar, but also depression. So psychoeducation means regular sleep. Psychoeducation means don't eat, drink too much coffee, don't look white screens at night that decrease melatonin, the usual things that you know. Second step, dose adjustment. You can increase or decrease the dose. And of course, some of the effects are dose related, so you can manage the dose. Or you can switch if it doesn't work. If you cannot switch, then you can use some combination therapy like modafinil. You know, modafinil is an off-label drug for depression, but is used in neurology, is increasing wakefulness. The mechanism of action not well known, but it works very well. Sometimes I use it, it's quite good. Or combine with different profile antidepressants, bupropion, for example, or low-dose mirtazapine, depending what you have to do. And let's go to the last side effect that we will discuss today. We published more recently, 2 years ago, with Vincenzo. Gastrointestinal. Gastrointestinal is another quite problem, a serious problem for antidepressants. Many of them indeed give nausea. Some of them give vomiting, and some of them give diarrhea or constipation. This is quite common. I have many patients that complain this. So it's important to know which ones and what. Let's start from diarrhea. The higher is sertraline. And this is not surprising. I think is also in your clinical experience, sertraline is the one that gives more diarrhea usually. And sometimes patients complain a lot about that. Followed by fluvoxamine, but with a large range, escitalopram, citalopram, and duloxetine. So you see how these results is interesting also from the pharmacodynamic profile of the drugs. Citalopram gives more weight gain because it's more anticholinergic. But being more anticholinergic gives less diarrhea. Understand, no? Because of course, if you are more anticholinergic, you have an increased appetite, but then you have a reduction of the bowel movement. So the data speak very clearly. And in this case, escitalopram is given more diarrhea than citalopram, and duloxetine, that is even more anticholinergic, is lower in terms of diarrhea. Constipation. Constipation, that is the opposite. You see more or less the opposite, but we had more data, so we have more drugs here. That, of course, the more that are more anticholinergic in general, histaminergic, are higher in terms of constipation. And the one that are more dopaminergic, like bupropion and multimodal, vortioxetine, are the one that give less constipation. So this is something to keep in mind for diarrhea and constipation. But let's look at nausea. That, at least in my experience, is the most common problem that we have with SSRIs. Nausea is very interesting because the odds ratio of having nausea and vomiting compared to placebo is very high. We are talking about 4. For duloxetine, vortioxetine, this is less used, a little bit less for venlafaxine, and sertraline a little bit less. Duloxetine and vortioxetine. This we will see later that is very dose related. Particularly for vortioxetine, I've seen that below 15 or 10, there is no nausea at all. But when you go above 15, 20, in some patients, there is literature, you can go also to 25 or 30 above label with vortioxetine, then nausea there is present. Not in all of them, not very severe, but is present. And this is for sure. So this is the general number, but low doses are better, high doses probably are worse. And fluoxetine and bupropion, they have a low dose of nausea. Well, this was a little bit of a surprise for me because I was expecting fluoxetine to give some, but probably there is an interaction also with the dopamine receptor that compensates the serotonin effect. Also, fluvoxamine was surprised because it is considered a very nausea-inducing drug. I was expecting to see here fluvoxamine, but data are like that. Anorexia, reduction of eating, that is more or less in the same range. Fluvoxamine, desvelafexine, venlafaxine, and vortioxetine. And dry mouth, that is clearly linked to anticholinergic effects. So nausea and vomiting are very common. Of course, it is due to the serotonin receptor 3. The only one that is not giving nausea and vomiting is mirtazapine. But mirtazapine is a different mechanism of action compared to the other. But they are very dose dependent for many drugs, citalopram, but also for vortioxetine. So what to do to manage the gastrointestinal side effects? As usual, try to do something simple. Try to adjust the dose, try to switch the medication, try to divide dosing. This is sometimes useful. Divide dosing means half the morning and half in evening. So we reduce the peak, the plasmatic peak. So two administration in the day or even three, the plasma level is more stable. You don't have the peak in the plasma, and the peak is the one that gives more nausea. So try to divide dosing. This is very useful. Take medication with some food, even if it's not in the label, or you can add something as usual, the usual gastric protectors, histamine 2 antagonist, or even more promethazine or ondansetron that are much stronger, or you can combine with mirtazapine, like you combine bupropion for weight gain, you can combine mirtazapine for nausea because it compensates the effect. And for diarrhea and constipation, of course, you can give the typical usual antidiarrheal agents if needed. If there is constipation, you can give probiotics or psyllium is a natural thing that I use a lot, very useful. Adequate activity, fluid and fiber intake, psychoeducation, and some soft laxatives. Laxative soft, this is important because if you give very strong laxative, there is a big risk of tolerance, and then I saw many cases of blocked bowel for long use of laxative. They are very dangerous, be careful. So we are going to the end. We are just preparing a paper now. This is not the paper, it's just the figure of the paper that we published in the next month. That probably many of the side effects of the antidepressants are due to their action on the microbiota, bowel. And we've seen indeed that many antidepressants change the bacteria that we have in the gut. And the bacteria that we have are very important because they are connected with the brain. They have a lot of loops, but not only. And so they can change the function of the brain in terms of mood, anxiety, desire of some food or others, inflammation. So the effect on microbiota is probably mediator of at least the gastrointestinal side effects, but probably also the other side effects. So it is a new frontier. I'm just telling you, no results, not clear results now. This is small, you should not read, but it's not important to read. In the future, you will have more clear which are the bacteria that are improved by the antidepressants that are good, and the ones that are decreased by the antidepressants that are less good. But at present, still is under research. What is clear is that the more different bacteria you have in your gut, the better it is, the less species is bad. And antidepressants improve the number of species. And the final point that is not commonly discussed in terms of side effect, because it's not exactly a side effect, is the withdrawal. When you stop the medication, some medications that you stop create more withdrawal syndrome than others. So it's important that you know that. It's quite common knowledge that paroxetine and desvenlafaxine and desvenlafaxine are the ones that give more withdrawal because they have short half-life and because of their pharmacodynamic profile. So I had patients that stopped paroxetine, maybe by mistake. They had very severe withdrawal syndrome, insomnia, feeling of electricity in the head, anxiety, nausea. So withdrawal syndrome is something quite to be considered, while other antidepressants have much less withdrawal syndrome, escitalopram, citalopram, and fluoxetine because of the long half-life. So also remember this figure because this is also a relevant difference across the tolerability of the antidepressants. And then we are going to the end. This is just one of my reviews where I try to discuss this point to show to clinicians like you the importance that we have to choose one of the 40 antidepressants that we have in the best way as possible, considering every aspect, the tolerability, the half-life, the symptomatology of the patient. It's quite difficult. It's not just, oh, I have depression, okay, this is sertraline. No, 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 no. You have to see which kind of depression, medical history, a lot of details, and then to understand all the antidepressants, which is the best for him or her. It's quite complicated. You can read something there. And the final slide about future perspectives. I made another presentation in Turkey about this. You can find it in YouTube channel. So here it is just on a slide. But just to tell you that the future antidepressant will solve many of the side effects that we have at present with the antidepressants. And not only solve the side effects, but also improve efficacy. Because the new antidepressants, many of them are effective in days or even hours. So when they are all on the market, our way of working in 3-5 years will be completely different. So you know some of them. Ketamine, esketamine is already available in the market. We are already using in Turkey, probably not everywhere, but many are coming. Dextromethorphan and bupropion, very powerful antidepressants, very well tolerated, useful in a few days, and no side effects, almost no side effects. Similar, the ones that are coming now, the neurosteroids, zuranolone, Prax 114, that are used for postpartum depression, but also for depression, also for anxiety, very useful, very well tolerated. And all the psychedelics, psilocybin, ayahuasca, that are gaining much interest, and other treatments like microbiome modulators that I mentioned you before, and of course the future of genetic and pharmacogenetics. So, but all these treatments will be available in the market in the next 3-5 years. And they are very different from the one that we are used to. So I suggest I'm publishing now a couple of reviews in 2 journals that describe this one by one and to show you which are the benefits or which are the difference one from another. Well tolerated, effective. Of course, they are not perfect for every patient, but it's important to know them. So the last slide, in conclusion, first line antidepressants, more or less have the same efficacy in depression. and in other disorders, of course. However, their tolerability is very different, very different. It is very important for you to know it because a personalized and careful choice and management is crucial for compliance, mainly, and effectiveness of the treatment. So this is all. Thank you for your attention, and we can have some questions.